is Janice Lopez from the International Organization for Migration, and welcome to the Migration Health Research Podcast. In this issue of the Migration Health Research Bulletin number 24, we feature studies, reports, and guides related to COVID-19, HIV, tuberculosis, and other topics relevant to migration and health. In this audio podcast episode, we spoke to Dr. Anna Requena-Méndez from Karolinska Institutet, Sweden, and Barcelona Institute for Global Health, Spain, who discussed the Electronic Personal Health Record, or EPHR, which is a health information system that registers health data on newly arriving migrants, and how the EPHR was used to describe the health problem and health status of migrants. Let's listen to Dr. Anna Requena-Méndez.
The objective of this study was to present the electronic patient record tool and also to describe the health problems and health status in the migrant cohort that we were seeing in the study period. But before going for that, I would like to address that in general and as a background, there is a need to address the health of migrant population. And this has been highlighted in the United Nations Summit for Refugees and Migrants, but also reflected in the Global Compact for Safe, Orderly and Regular Migration. So having data is essential to have available, disaggregated and comparable data on migrant health. And this is key in order to have a good understanding of the health needs of migrants and also, of course, for public health planning. Therefore, the electronic patient record is a health information system for new arriving migrants, which allows recording of the medical history, diagnosis, signs and symptoms for first and also for follow-up consultation. This health information system was developed by the International Organization for Migration as part of the European Union funded study. And then what we did is just to try to present this electronic patient health record tool. And also, again, as said before, to describe a little bit all the health problems and the health status that we were finding in the migrant cohort that were attending for a medical problem or because they underwent a comprehensive health assessment in the reception and the health centers. So this health information system was implemented in different settings of several countries, was implemented in Italy, in Croatia, and Slovenia and Greece during 2016 and 17. And then in the second phase, during 2017 till 2019, 4 new countries were added, which were Bulgaria, Cyprus, Romania, and Serbia. However, since the facility is located in Romania and Slovenia, the tool was implemented only as a pilot test. Therefore, they have not been included in the study for the purpose of the data analysis.
Can you tell us the methodology that you have used for this study?
The methodology basically was conducting a cross-sectional study, and therefore all migrants who underwent either a consultation or a health assessment between 2016 and 19 in all reception centers for migrants in these 8 European countries, with the exception of Romania and Serbia, as said before. So we're including in the study. All these migrants that they were attending this center were considered new arrived migrants. They arrived usually few months prior or certainly within the last 5 years. And then they were included in the study. And then we were basically analyzing all the health records, what happened with these individuals, what are the diseases, the medical past history, including journal records. This means that we were manually reviewing or trying to do algorithms for extracting data on the diseases that they were having, these populations. And we were including infectious diseases, but also non-communicable diseases. We were including mental health problems, injuries, etc. The routine screening for infections or other diseases was not systematically performed. So therefore, we were only just extracting the data for the patients or for the individuals that they had been done a blood test. Also, for example, specific investigations such as electrocardiography, radiography, or specific blood tests were only performed for patients where the history or examination prompt the need for such kind of tests. This means that this is not a screening program and this is not like a prevalence. We could not determine the prevalence of the infections. We could only determine the proportion of cases of different diseases that we were having in the health information systems. Then we were using a question questionnaire for the health assessment of migrant population. This questionnaire was including past medical history, but also immunization records, exam and laboratory findings, diagnostics, and also summary findings, and travel and post-arrival recommendations. However, for example, for the purpose of this study, vaccination data were not available, so we were just focusing on the diagnostic patterns of infectious and non-infectious diseases.
Kindly outline key findings that you think would be worthwhile to share to our listeners.
First of all, is just that this study is providing a sort of a snapshot of health and disease among vulnerable migrant populations which arrived to Southern Europe between 2016 and 19, and it has been reported through the EPHR, the Electronic Patient Health Record. And then the picture that we see is like a young, mostly healthy populations with many acute infectious diseases episodes, particularly in children. For example, we have a lot of skin infections and also respiratory infections in children, but also with a by no means insignificant number of chronic conditions. And this can provide important lessons for healthcare and public health. For example, in particularly, adult women were found to present more cardiovascular diseases compared with adult men, and these results have been also observed in a complete case sensitivity analysis that we did. These findings is contrary to somehow the established literature. However, other studies have also reported that migrant women had more risk factor for cardiovascular diseases compared with men. And I think that this study is highlighting that probably we need just to have more data to elucidate the relationship between cardiovascular diseases in adult women. This could be also an artifact of the migrant population, and it could be partially explained by a different health-seeking behavior, for example, of migrant women compared with men. But again, we need like a further explanation for that. Also, we found a high proportion of diabetes mellitus cases, particularly among underweight or normal weight individuals, which is also interesting because that is a little bit different compared to autochthonous population. And these findings have been also reported in migrant population from sub-Saharan African countries in other studies. So this could be explained, for example, by a metabolically unhealthy normal weight. What else? I would say that, as said before, in keeping with other studies, similar populations, we find a high proportion of infectious and also musculoskeletal disorders, and common skin and acute respiratory infections have been observed in children. Surprisingly, injuries, for example, were less frequently reported, which is similar compared with other studies in refugees. However, there is literature evidence of injuries associated with the precarious conditions of temporary installations. I think that this may be setting specific as supported by our study, but also I think that we need to understand much better how well the medical doctors are registering the information of injuries into the electronic patient record system, because we were using ICD-10 codes, which is the standard classification for diagnostic, which is an international tool that is describing very well the kind of diagnosis. So if in the end the medical doctors or the health professionals that are entering the information into the health information system are not registering well these kind of injuries, for example, then probably there can be a misclassification of these conditions. Also, we found a relatively low rate of personal or reported mental health conditions, which is lower compared with other publications from similar settings. But we need to take into account that many studies, that they are prospective cohort studies, basically they are like conducting surveys, which is included like a validated questionnaire where they are actively seeking for mental health conditions, whereas in our case, we were just retrospectively collecting the data on potential mental health problems that they were registered, again, by health professionals using an ICD-10 code diagnostic. Therefore, it's very likely that we are underclassifying mental health problems or having like a lower proportion of mental health problems because of this issue in compared with other countries. And then for the second part, I think that we need to highlight from our study that we are presenting this electronic patient health record tool. And then this tool is providing a unique opportunity to compile data from highly variable and poorly equipped migrant reception settings. And it shows its utility for securely recording and transferring medical information between clinicians and even across countries.
So as my last question, what does this piece of research aim to say to policymakers or program managers, in particular on the importance of electronic personal health record or health information system in general?
Well, I think that this study was a first step to describe the data that we found. But in addition, I performed also a feasibility assessment of the electronic patient record itself. And I think that a future study should better elucidate the sustainability of this electronic personal health record system, and also, for example, to compare it with other software recently developed, and that they were also aimed to improve the data collection of the health information system, such as Health Workforce Information System software or the DHIS2 software. So I think that we need to understand better how we can use these electronic health records across countries in these mobile populations, because that is very important and very useful. And then it's very important to understand that this kind of electronic patient records may avoid, for example, duplicate tests. Imagine that we have a migrant person that crossing different European countries, and then they were vaccinated for DTP, for example, for tetanus, pertussis, and diphtheria, and then he goes to another country, and then in this country they may have already the information available about all the blood tests, all the vaccination that they were receiving in the first transit country. So I think this kind of health information system may avoid duplication of tests, over vaccination of populations, because these records will be efficiently tracked across the migration journey, and this will prevent that important diseases, for example, drug allergies, are missed, and also this will improve the patient care. Therefore, this will definitely benefit migrants and refugees, but also will protect the public health of host countries.
Thank you very much, Dr. Anna, and thank you all for listening. Please feel free to share feedback with us. See you on the next podcast.